started this morning with grand rounds. Our visiting professor this morning is Dr. Caron from the Department of Neurosurgery. Dr. Caron is a native of Montreal, or at least somewhere close to that name city, right? He went to medical school at Ottawa and then did both general surgery and his neurosurgery residency at McGill, and then was on the faculty there for 18 years. Had one other appointment before Dr. Hemicraniectomy, the chairman here, recruited him to come and join the faculty. And this morning he's going to be talking about traumatic brain injury that requires hemicraniectomy. Dr. Caron.
Can you hear me with this microphone? Okay, good morning. Thank you for the invitation. You hear me now? What I want to talk to today is something that we've been developing over the past 5 years since I came here, 7 years. And it's the use of emergent hemicraniectomies in neurotrauma. In association with our traumatologists down in the ER, we interact a fair amount to care for some of these patients who are deathly ill, deathly injured, and making rapid decisions as to how to manage them. So I call this really the challenging management of severe traumatic brain injury. Now, this is a joint effort. First of all, I have no disclosures, but it's a joint effort from my entire department. I'm the so-called principal investigator for this. Gentry Savage is a PGY-6 who has been doing a lot of the background work for this. Carol White is a PhD in epidemiology who's been doing a lot of the calculations and looking at the numbers, and all my colleagues in neurosurgery. We also have the addition of Dr. Para, who's a neurocritical care specialist. He's a neurologist, and it's kind of changed a lot of the paradigms of how we treat a lot of these patients. And of course, all the residents who are caring for these folks, including the surgery residents and our associates in trauma surgery. So just in the background, traumatic brain injury is a very important cause of death and disability worldwide. It's not just localized to developed countries and so on. And it's a very big problem. These are statistics from the CDC in 2010. So over 1.7 million head injuries, 275,000 hospitalizations, 52,000 deaths, and almost $6 billion in lost revenues and so on, and productivity. And if you look at the cause of these, if you take all comers, surprisingly, well, 35% are from falls, close to 20% are from motor vehicle and traffic accidents and so on. It's not surprising that falls are the most important ones, but most of these things are the benign ones. What we are interested mostly in our field would be, I don't have a pointer, the groups which are in the motor vehicle crashes and also the falls which are not trivial. So fall from a height, fall from a plane, fall from when your parachute doesn't open kind of stuff. So more severe injuries. And as hospital surgeons, what we really deal with is a subgroup of the top of that pyramid. And we try to find ways that we can decrease the amount of deaths, obviously. The best way is prevention, but when you can't prevent it, what could we do as neurosurgeons or trauma surgeons to try to modify that number? Back in 1986, a neurosurgeon by the name of Gajar got a big grant and created this foundation. It's a brain trauma foundation. And the first thing that foundation did is gather all the experts around the country into this field, people who had interest in taking care of neurotrauma, and try to come up with some guidelines as to how to manage these folks. And they came up with a significant amount of information. And most important for us is prognostic factors, of course. And what we found is that in terms of determining how somebody's going to do when they arrive through the ER door is their level of consciousness. So we use the Glasgow Coma score, which is a very simple way of examining these people and coming up with a score based on motor response, pupillary eye response, verbal response. And the score is from 3 to 15, and 15 is normal, 3 is very bad. Anything under 8 is a severe head injury. Between 8 and 12 is a moderate head injury, and 12 to 15 is a mild head injury. The other thing was age. Anybody over 40 seemed to be doing much worse than under 40. And 40 is not very old for most people. But age is very important. And surprisingly, the presence of hypotension. If you had one episode of a systolic blood pressure under 90 millimeters of mercury, your chance of dying was almost twofold, even if it was not very long sustained hypotension. So hypotension was very bad. Pupillary response, if you have unreactive pupils, chances are you're not going to do well. That's pretty much of a given. But if you have one pupil not responsive, if you have just like sluggish pupils, again, these are things that you can examine in these people who are unresponsive. We have multiple injuries, difficult to access, difficult to really get a response from anything. And, of course, the CAT scan findings. Now, the CAT scan findings, CT findings, I'll go over in detail because although it's old information and dates back from a traumatic coma data bank from 1991, it's still very, very pertinent. Let's look a bit of applied physiology. So this is going to be pretty basic, but it just explains to you the concepts of how we want to manage these folks. So the cranial vault is like a can of tomato soup. It's a fixed volume. You can't expand your head. It's there. And the volume inside your skull has to contain a bunch of stuff. And it has extracellular fluid. It has cerebrospinal fluid. It has blood, and it has brain parenchyma. Now, a lot of these things can be switched over to accommodate something that is growing inside that fixed volume. So you can squeeze some extracellular fluid out. You can squeeze some CSF down into some other space, like down into your spinal column. You can reduce blood volume by contracting the blood vessels and dropping off the blood flow. And brain parenchyma has a certain amount of compliance, so it's somewhat squishy. So this whole thing comes to the concept of intracranial compliance. Now, intracranial compliance, I'll go back to this one, is not a direct relationship to the pressure. So if you try to put more stuff into that can of tomato, you'll get a direct relationship of volume to pressure. The more volume put in, the pressure will go up exponentially almost. With this concept of the Monro-Kellie Doctrine, which dates back to not that long, but the 19th century really, in animals models, but it holds true for humans, is that you have this intracranial compliance. So as something grows inside this volume, so the intracranial volume, you're able to compensate for that volume and maintain normal physiology, normal intracranial pressure, up to a certain point. When you get to a certain point where you're no longer able to compensate for that volume, the pressure will rise dramatically. So that a very small increase in volume will produce a very large change in pressure. And so physiologically, someone would be doing okay and then deteriorate very fast. So that's why you see sometimes really rapid deteriorations in these people. They'll go from talking to you to being dead within a few minutes. The other corollary to this is that some forms of treatment uses this paradigm as well. So that if you drop the volume by a very small amount, you'll drop that intracranial pressure by a very large amount. And that's what we do in the emergency room. So if I go back to this, the intracranial pressure, we know that normal pressure is between 0 and 15. We all harbor around 5 millimeters of mercury or so. And pathological pressures are over 20 millimeters of mercury. And you start getting displacements or shift around 40 millimeters of mercury. And if you have pressure sustained around 40 millimeters of mercury, it becomes incompatible with life. So this is data that dates back mid-80s, early 90s. And so I wasn't going to dwell upon all the studies that looked at that. But an ICP of 20 or more is pathological, and that's what we try to aim at, keeping it below. We know that we can reduce mortality if you keep the ICP below that number. The other principle is blood pressure. If you look at this particular diagram, the lower portion is the intracranial pressure, and the mid one is the mean systolic arterial pressure. But you can imagine if your intracranial pressure is equal to your mean systolic arterial pressure, you'll have no blood flow. And it's the same equivalent, it's equivalent to having a cardiac arrest. So what we want to do is maintain a certain perfusion pressure that will sustain blood flow and adequate metabolism to an injured brain. Now, normal cerebral perfusion pressure is usually around 40, 50. In animal models in particular, and we've applied this again to human subjects, is to try to keep that cerebral perfusion pressure above 60. In the past, you used to say above 70, but there is some data to suggest that if you drop it, you bring it over 70, you increases the big problems of pulmonary complications. So you want to keep it at 60. And CPP is basically the mean arterial pressure minus the intracranial pressure. So you have those two basic measurements, you're pretty able to kind of maintain some of the intracranial homeostasis. What we do to measure the progress of these people is a very simple scale. It's not perfect. It just takes the best response that these people may have. So you can have somebody who's got total hemiplegia, but if he's got some response on the contralateral side, you use that as a number. So we use eye opening, motor response, and verbal response. And this dates back to the late, mid-70s, and we're still using it. And we're still using it inappropriately. We're still having a hard time measuring these things, but it gives you a simple way that you can measure neurological function in the field. You can measure it in the ER, you can follow them in the intensive care unit, and you can create these little graphs and show the progress of these of the course of events. So someone who comes in the field as a Glasgow Coma score of 12 for a moderate head injury, and he gets to the ER as Glasgow Coma score is 7, you have a pretty good idea there is something is evolving within that intracranial content, and you start thinking about mass lesions and so on, and they're decompensating for some reason. If they have a Glasgow Coma score of 12 in the field, and they have a Glasgow Coma score of 12 in the ER, you're pretty sure that things have a static type of an injury, and it's not progressing in time, and you may be able to concentrate at other things, and perhaps the brain may take a secondary importance. Now, what happens when the pressure goes up even more, and you get into lateralized lesions like an epidural hematoma, subdural hematoma that we see? You get these shifts of intracranial contents. So the intracranial, it's not like the can of tomato juice, like I showed you, there's some compartments. There's a falx, there's a tentorium, and so anatomical compartments in the skull that allows this mushy brain, which is the consistency pretty much of jello, to be squished around in there. And the worst thing that can happen is transtentorial herniation. So that's when somebody you call, he's coning, he's herniating. The principle is that the lateral shift is pushing onto the brainstem and it's compressing the cerebral peduncle on the ipsilateral side, producing a contralateral hemiparesis or hemiplegia. It's also going to be stretching that third nerve that comes out just at that level of the midbrain, and it's going to start dilating that pupil. The pupillary fibers on the third nerve are outside of the nerve. The motor fibers are more deep in the nerve. So the first thing to go is pupil dilates. So the pupil dilates, and then you get the motor paresis of the eye and the classic third nerve palsy. Also, the reticular formation is in that region, so you get level of consciousness decreasing, but you also get decreased level of consciousness because the intracranial pressure is going up, and you're getting diminished blood flow and cerebral function. And typically, this is what you see. The dilated pupil, the eye deviates out because the sixth nerve is unopposed, so the eye deviates out, and you have decreased consciousness in the subject. And if you really examine them, they might have a contralateral hemiparesis. They might have even more primitive reflexes like extensor posturing or flexor posturing, which we used to call decortication and disorbit posturing, which are all lower levels of function in the brainstem, really. And pathologically, what happens is you injure the midbrain, you get these hemorrhages in the pons and direct, and it's the common pathway for cerebral death in a lot of these patients. I put this up because we always have to remember that A lot of these injuries may be isolated to the head, but they're often multifactorial, and that's pretty much what we see the most here because of our urban lifestyle, that they have other injuries which contribute to the whole picture. So the diagnosis of the head injury, sometimes it's not very obvious. You may have someone who you think is intoxicated, is on drugs and so on, so it kind of blurs the picture. So to make the diagnosis, especially in the ER, I just use like, okay, there's an obvious history of trauma, and you try to find out what the mechanism of injury was. So a trivial fall is very different than a high-speed motor vehicle crash, obviously. So the force of the injury and associated injuries that are present. If the person is hypotensive and intoxicated, then it might change your view of things. Then we use a post-resuscitative neurologic examination. So you want to have these people went through the ABCs and they're stabilized in terms of the cardiovascular system, oxygenation system, so you can get an idea of really what's going on in that brain. So we use the Glasgow Coma score, and we use a pupillary response, and we use a CAT scan to really guide us in terms of our diagnosis. So these are just some examples of CT scans that we are obviously seeing. This is an epidural hematoma. It's a lens-shaped type of an injury that you see, and it's pushing the brain over. CT scan is really the workhorse, as you know. You can get it very fast, and it shows blood at a very, very early stage in the game, as opposed to MR scan, which is not readily available, and it's not very accurate for hyperacute blood, and it's not fast. This is an acute subdural hematoma. The subdural hematoma covers the entire hemisphere, so it just follows through that way. And again, similar thing where you get pushing and compartment shifts and increase intracranial pressure. These here are examples of parenchymal lesions, so contusions. You have your brain that kind of squishes into this skull cavity, has corrugated base, and typical injuries are at the tip of the temporal lobe and both frontal lobes. And these things can coalesce and form large hematomas, as you know as well. But the other thing that we see very frequently is so-called diffuse axonal injury. You get these shear forces in the brain that are transmitted across all of these structures. You have the neurons on the surface, some neurons on the depth. All the white matter is really axons, which are myelinated, and with the sustaining neuropil, which are made out of astrocytes and oligodendrocytes and so on. So if you shear these, you can disrupt a lot of the neurological function, and you set something up that's called secondary injury. So you get the glutamate cascade, and eventually it leads to cerebral edema. So this is a devastating type of a picture, and this is the one that is of interest to this particular discussion. Now, if you notice on this scan, there is a very small rim of blood on the right side. It's a small subdural. But if you look at the CT scan, it's kind of grainy. You lose the differentiation between white matter and gray matter, and you see these little specks of white stuff, and it's felt that there's small petechial hemorrhages deep in the white matter. The other thing that you notice on the scans on the left side, on the right side here, is that you lose the basal cisterns. There's usually CSF space there, but the brain is full, and it's just that kind of gray, snowy base, and you lose the basal cisterns. And those are not good signs. And we know this from a study, was published in 1991. Marshall is the principal investigator of this. It's the National Traumatic Coma Data Bank. They studied a cohort of 790 or so patients in a registry, trauma registry, and kind of looked up at what are the prognostic factors, what happens to these folks, and so on. And they came up with a CT scan gradation for this. And this is published in 1991, and we still use this. It's very good data that and hasn't changed really much over time. The picture that I showed you before would come in the category of diffuse injury type 4, where there is a midline shift more than 5 millimeters. There's no high or mixed density lesions. That means there's no clots, which are greater than 25 cc's. And that subdural is very small. So that would be a diffuse injury type 4. A diffuse injury type 1 is a normal scan in a non-conscious patient. And these are all with severe head injuries, so Glasgow Coma scores of 8 or less, and some moderate, 12 to 8. So our interest is in patients with diffuse injuries type 4. The ones with mass lesions will go to surgery. The ones with totally fixed pupils and have unsurvivable lesions will not go to surgery. And there is this big black area where what should you do with some of these people? So the guidelines of surgical management of traumatic brain injury were published in 2006, and it's a joint effort from the Brain Trauma Foundation and the Congress of Neurological Surgeons. And they went through the literature and gave recommendations to the management of various intracranial traumatic lesions like subdurals, hematomas, epidurals. And when it came to the diffuse axonal injuries, this particular picture of a diffuse type 4, there was really no consensus as to how this should be treated. And the guidelines at this point were to follow really what the guidelines for management of the severe traumatic brain injured patient, which were published pretty much at the same time by a bigger joint group. And this was just rehashing the initial publication, which came out in 1995, which also came through as a result of the traumatic coma data bank, and came up with these guidelines as to how to manage these folks. And patients with traumatic injury type 4, severe head injury, were to be managed medically with an intracranial pressure monitor, intensive care unit, and maintaining the homeostasis to maintain the blood pressure, the cerebral perfusion pressure above 60 and the intracranial pressure below 20. So those are what we call the TBI guidelines, and that's what we're doing in most of these cases, right? So how do we maintain the pressure ICP below 20 and the CPP above 60? Well, we use a variety of techniques. We can use hypertonic saline to shrink the brain down, so decrease some of that external cellular fluid. We use external ventricular drainage, so you can reduce the CSF space, so then you decrease some of that intracranial volume to accommodate the extra space that the lesion has taken. There's been some studies looking at moderate hypothermia. It was very, very popular in the 80s. We keep these people down at temperatures of 35. Some of the studies that were published showed that it made no difference whether you cool them down. But there's a lot of problems with a lot of the studies that were done, is that perhaps the hypothermia wasn't done long enough. It took too long to get them down to 35. Should you keep them hypothermic? Because we know that hypothermia will drop the intracranial pressure, but it didn't really change the overall outcome of these folks. But you can still use it in certain cases. And also barbiturate-induced coma, where you just like put the brain completely at rest. Very effective in taking care of raised intracranial pressure. So the first line of treatment is your ABCs, you take control of ventilation and so on, and using hypertonics, either saline or mannitol, to maintain the intracranial pressure. So this is just a summary again of what we do. When you start getting into problems, you've tried all this, you've maximized the medical therapy, you've maximized the hypertonics and dehydrate them to the point where you can't anymore. Their osmolality is 320 and you get into trouble, and the intracranial pressure is still elevated. Then you start thinking maybe there are some operative considerations that should be taken. And that's why we consider decompressive craniectomy. Now, decompressive craniectomy there's a variety of techniques to do it. It could be bifrontal, it could be hemispheric, it could be bihemispheric, it could be just subtemporal. So there's really no consensus as to which is the best technique for this. Is indicated or recommended by the trauma guidelines only in certain situations where you have refractory intracranial hypertension that is not amenable to the maximum medical therapy. But we know that if you do decompressive craniectomy, you'll reduce the intracranial pressure. And we know that raised intracranial pressure is associated with a poor outcome if it's not treated. So going back to Marshall's CT grade, he took his CT scan grades and then correlated that to outcome in severe head injury, so people with Glasgow scores of less than 8. And, sorry. And if you look at the diffuse injury type 4, which is the type of patients that we're talking about, they didn't have very large numbers. That's out of 746 people, patients. Only 6% really had a satisfactory result with the medical treatment that they had. So it carried a very, very high morbidity and very high mortality, and a lot of it's based on the fact that you had uncontrollable intracranial hypertension. So I'm taking this paper as an example, but there's been a lot of interest in using, taking the decompression of the skull to make room for the brain. And I mean, it just kind of makes sense for a surgeon, I suppose, right? But there are all small series, uncontrolled, and there's nothing like the lack of a control to get a good result. So all these small series were all positive. Everybody's doing, oh yeah, they all do better with this decompression. They all do better with the decompression. And this paper was published in 1997, and that's really the first one that kind of tried to get a control group, but they're a control group. So this is, he looked at the retrospective cohort, 38 patients, compared them to similar patients matched from the trauma data bank, which was published 10 years before. A lot of things happen in 10 years in terms of medical management and so on, and we know that innovations occur. So it's not a really good group, but they also just spiked the idea that if you do decompress them, they might do better. And they're a group that seems that the earlier you did the decompression, the better. But these were all in patients with refractory intracranial hypertension. His technique in this particular paper was bifrontal craniotomy, very complex surgical procedure, and associated with a lot of complications that are associated with this. And basically is removing both frontal bones and opening up the dura and allowing the brain to kind of expand out. And this is kind of the picture you would get on a reconstructed scan. And you can imagine the brain just being able to pop out of there and relieve the intracranial pressure. And it's very effective in reducing intracranial pressure. The other technique is to use a hemicraniectomy. So if you remember these type 4 injuries, they have more of a hemisphere injury and it's pushing over. Although they do have a diffuse brain injury, there's one hemisphere is hurt more than the other one. So you can apply this technique. And it's something that we've been using, and I'll show you later. And this is the picture you get from that hemicraniectomy. And again, you got lots of room for the brain to expand out. So after 1997, a group from Australia and New Zealand decided that this needed to be studied. They did a pilot study. They thought perhaps that it was feasible. And this was published in April of 2011. And it's a DECRA trial. It's called a decompressive craniectomy, diffuse traumatic brain injury. Now, their protocol was to treat ICPs which were greater than 20 millimeters of mercury that didn't respond to first-year management for 15 minutes in the ICU. So patients came in, they were taken to the ICU, the EVD, ICP monitor, just maximum medical management. If their intracranial pressure got over 20 and did not respond to first-year treatment, they were randomized, either surgery or continued medical management. And they randomized our patient within the first 72 hours of the injury, and then looked at the two differences, right? The medical group, about 18% down the line, underwent hemicraniectomy because they kind of failed. But there are some problems with a lot of the data that happened with this trial. Sorry. So what it shows is that hemicraniectomy, in this particular slide, the blue line, decompressive craniectomy and standard of care, this is just ICP over time. The intracranial pressure is very well controlled with the decompressive craniectomy. So we already knew this, but this really puts it on the map. So it's very effective in taking care of ICP. Unfortunately, in their group, people who had decompressive craniectomy did worse. Their outcome were worse off. So this is called an extended Glasgow Coma score. It goes from 1 to 8. Anything under 4 is bad. Everything over 4 is acceptable. There were more patients in the bad group in the decompressive craniectomy. And this is another way of looking at it. The dark bars are the decompressive patient, and the gray bars are the medical management patient. And you can see that they were worse off. And you try to say, well, why is that? This goes against what all of the anecdotal studies were suggesting, right? So another disappointing thing. So you look at their data in a bit more details. There were no difference in the deaths. What happened is that decompressive craniectomy created more patients in the vegetative state. Why was that also? You'd think that it would also come down, you get better patient with better outcome, but it didn't happen. If you look at the cause of death in these groups, most of them were not due to brain death or something like that, but were due to withdrawal of care. But it's pretty equivalent on both sides. So the deaths were similar. There were a few more brain deaths or progression to cerebral death in the medical treated group. But really what you looked at is, so on the left is the surgical group, on the right is the medical group, is that they didn't have equal proportion of patients in both groups. The randomization process, again, failed to a certain degree. They had a larger group of people with unreactive pupils in the surgical group, and they had a larger group of people in the surgical group with more severe CT scan injuries. Maybe not a large number, but significant enough to perhaps to make that difference. So the idea is that the decompressed patients were sicker or had worse. So that data still needs to be taken with a grain of salt. But that's what we have. This is the only randomized controlled trial looking at decompressive hemicraniectomy using a bifrontal decompression in patients with refractory intracranial hypertension. There's another study going on. So that was an Australian group. There's a British study that's happening in parallel, and it's called Rescue ICP. And their criteria is a bit different. They will not accept patients with bilaterally fixed pupils, although DECRA said they didn't either, but it just happened that there's a whole bunch of them in there. Some of these patients will also be allowed to have had a craniotomy before, as opposed to DECRA didn't. And also, their criteria for ICP is different. They will take patients who are unresponsive to maximum medical therapy, including barbiturate coma, but also their cut point will be 25 millimeters of mercury and unresponsive treatment for 6 to 12 hours. So they're going to be pushing things out and making things look more like in real life that we're doing, as opposed to taking people who maybe would have responded in DECRA. And that was the other argument in DECRA, is that a lot of these patients would have done well anyways, because the ICP of 20 is not so bad, you can treat them. And didn't have really a chance to maximize the medical therapy. Now they're going to randomize 600 patients, 300 in each arm, to see a difference of 10% and a power of 80. They've already randomized 300 of those 600 at this point. The trial's been going on for approximately 4 or 5 years. And so it's going to take a little while, but it's going to add on a lot of information as well in this group. They also allow for a variety of techniques to be used, and they leave that to the choice of the surgeon based on the type of injury that these people have. So there's some data coming out, which is encouraging. And I was very surprised to see DECRA published in that. It was refreshing to see that somebody is actually studying a surgical procedure, especially in trauma and neurotrauma. So where do we fit in all this? I came here in 2004. I was involved in a trauma center when I worked in Montreal. It was nothing like here. We had about 500 or 700 admissions per year. I came to the first trauma meeting here, and they say, well, actually, when they hired me, they says, we know we're a trauma center. I said, I know. I've worked in a trauma center. He says, you know we're a trauma center? I said, I know. So I go to the first trauma meeting, and then you realize there are 300 admissions per month. You can correct me, maybe more. 350 in total. We see 900 moderate to severe head injuries per year. It's a huge number. So also when I came, or was coming here in 2004, the neurosurgery department was in turmoil, and all of the trauma was done by trauma surgeons. And trauma surgeons have a different mentality. And I put up this paper that was just recently published. And it's the experience of trauma neurosurgeons during Iraqi freedom and endurance, freedom and endurance what do you call missions in Afghanistan and Iraq. And they looked at retrospectively, and it's a retrospective cohort, 168 patients who had craniotomy and craniectomies in the field. So their attitude is, you bring these people in the field, you do whatever you need to do and ship them out. And when I talk to my colleagues who are in the military neurosurgeons, I mean, an injured person in Afghanistan will have a craniectomy and will be in Germany within probably 6 to 8 hours from the injury. It's an extremely efficient way of doing it. And I think in 2004, the mentality of the surgeons here, which were military trained, was of doing that. Because there was very, very few, I'm sure there's some people in the country who are doing emergent hemicraniectomy for diffuse type 4 injuries. But it's not standard of care. And we kind of evolved into this, and we started doing it for something. I think we just kind of picked up from the philosophy of the group that was here before us. And then all of a sudden you say, well, wait a minute, maybe we should look at this. Maybe we should look at it a bit more carefully, because there may be something there. So the tools that we used are classifications from the Marshall CT grade. And we're aiming at this particular group here, some diffuse 3, but most of the ones which arrive in the emergency room, they have a severe head injury. They have a CT scan which shows a small shift of 5 millimeters or more from brain swelling. They may or may not have a small subdural collection or a contusion, but it's not responsible for the entire picture. So a diffuse injury, grade 4. And here's a typical scenario. Same type of picture I showed you before. You get loss of the gray-white matter. There's all this kind of salt and pepper picture of petechial hemorrhages. You get loss of the basal cisterns and squeezing of the ventricles and shifting of the septum pellucidum. That's the midline structure. So if you draw a line along the falx and you measure the septum pellucidum, you can get that picture. You can measure that on the scanner. So this is what we do. We do this hemicraniectomy and restore the intracranial contents as much as possible with this. Now, this is done with the patient coming from the ER to the OR without having an intracranial pressure monitor. So we don't know what their ICP is. We just assume that it's up. Here's another example. Typical picture here. Shift of the midline. Basal cisterns obliterated. Do the craniectomy. Restoration of the intracranial contents to the midline as much as possible. And then down the line, get their bone flap repositioned. So the hemicraniectomy gets either placed in the pocket in the abdomen. What we've been doing is sending it to the bone bank, and it gets frozen. And then when the cerebral edema and so on comes off, if the patient has survived, undergoes a autologous bone graft replacement. So looking at this, we decided to do a study called eHIT. So eHIT is for emergent hemicraniectomy in trauma. It's a retrospective cohort study. It's to see how we're doing with this particular population. So our methods was to take the charts of patients undergoing cranial surgery between 2008 and 2010. We wanted a very modern or recent group because of the addition of our critical care people and so on, and being very aggressive with these folks. And we looked at adults, patients who had hemicraniectomy, presence of the TBI with injury type 4, and the surgery was performed emergently from the ER, mainly because the trauma surgeons are pushing us to do it. Get the guy to OR. So, but that's the way we've been doing it. And following the surgery, I'll just go into this. The surgery is a hemicraniectomy. It's a very large flap, 12 to 15 centimeters. This is the type of incision we do. It's a large inverted question mark, and try to get as large a flap as possible. Now, the reason for that is to avoid a lot of complications that can occur from this. This is not a benign procedure, as you can imagine, but the complications of the hemicraniectomy is a whole different discussion. So But there are complications associated with this, so they're not insignificant. So that's why making the decision to do this is not an easy one. So we do a stellate durotomy. We cover it with artificial type of dura, which allows easier dissection for the cranioplasty later down. We place an ICP monitor or a ventriculostomy for management of the ICP afterwards. Now, what we wanted to do is to get an observed outcome versus a predicted. Now, we don't have a control group, and it's easy to just say, oh, this is what we observed, and it looks great, just like the others did. But, you know, in facing DECRA, we're saying, oh, you need some kind of a control group. So what we did is use a predictive model that was developed in another study called a crash injury prognosis injury study, and we used the Glasgow outcome score as our measure for outcome. Now, the crash head injury prognostic model came from the crash trial, and that was published around 2002, I think. I'll show you again. 2005. Now, crash is a European and Asian study looking at the use of steroids in head injury. And they randomized 10,000 patients to this study. It was a negative trial for steroids. Giving steroids to head injury patients make them worse. But they had a very large database of people worldwide, some in developed countries, some in less developed countries, or big economies and more emergent economies. And they developed and validated a prognostic model. And the prognostic model takes into consideration a variety of things and gives you a mortality at 14 days and a predicted morbidity mortality at 6 months if you use medical treatment or use standard of care. So this model has been validated also in other trials. So we thought that would be perhaps a good way of comparing our patients. So what we wanted to do is take these patients, we use a retrospective cohort study, we plug the numbers when they came into the ER into this prognostic model. And here's an example. It's online. So you choose the country that you're in, you choose the age, the Glasgow Coma score, and so on, and you plug in the findings on the CAT scan, and it comes up with a 14-day predicted mortality with 95% confidence intervals, and also a risk of unfavorable outcome at 6 months using the Glasgow outcome score with confidence intervals. So we use that as our surrogate for a control. So what did we find? First of all, demographics. We have an aging population. Large number of the patients that we see are over 40, which is a bit surprising, but it's how it is. These are people who were treated. So we had 39 cases who underwent emergent decompressive hemicraniectomy. More patients had surgery. We do approximately 165 craniotomies for trauma a year, but in that particular 2 years, 39 fitted these criteria that we wanted. Most of them were severe. There was some moderate, and very few had a mild head injury who deteriorated further down the line. That's why he underwent the craniectomy. 8 patients died at 14 days, and 31 patients were alive at 14 days. What I want to show here is that most people who die, and that number 8, are in the severe group, which is kind of expected, and most people who died were in the older group, as expected from the prognostic factor as we know. Now, if we looked at the observed versus the expected mortality from the predicted model that we had in these patients, the prediction model we expected a death at 14 days of 24 patients. What we observed at 14 days is that only 8 patients died. So the prognostic model overestimated the number of deaths that we observed. And that was statistically significant. We see that there's almost a 70% reduction in mortality in the patients who had hemicraniectomy compared to a prognostic model had they been treated with maximum standard of care. And similarly with outcome at 6 months using the Glasgow outcome score, the model predicted an expected unfavorable outcome in 32 of these patients. We've observed an unfavorable outcome in 24. For a non-statistically significant reduction of 25% in bad outcomes. Now, the confidence intervals straddle 1. But there is a trend towards better outcome in this group using this. But again, the model overestimates the number of bad outcomes that can occur. This is the observed mortality at 14 days. And if you looked at patients who are in a similar predicted risk categories. So if you take these patients and you subdivide them, so a group that the predicted mortality was less than 60, predicted mortality 60 to 69, and so on, up to 100%. So blue is alive, red is dead. If you take the ones who had a predicted mortality of 90 to 100%, the mortality rate occurred as expected. If you take the ones which had a much lower mortality predicted, the good outcome was as expected. But if you look at the group between 60 and 80% prediction, then there was a surprise that the mortality was much lower than expected. So there might be a group of people in that subcategories that may benefit more than the others, so that perhaps we shouldn't be operating on these people here, and we shouldn't be operating on those people over there. And if we look at unfavorable outcome at 6 months for the same type of a picture, again, you see whatever is green, blue is good, and whatever is yellow or orange, yellow, and purple, and red is bad. You can see a trend as a prediction goes up. If you have a prediction of 90 to 100% from the prognostic model, you have nobody who's in the good category in terms of outcome. And then that middle portion, there's something brewing out there. And if we look at it differently, if the predicted model was perfect, you have a straight line up here. So that's a perfect line of prediction using that prediction model, the crash model. And this is what we observed. There is a group between 60 and 80% which are consistently below what would be the predictive model. And if you get to 100, then it comes pretty close to what prediction should have been. Now, what does this mean? It means one of three things. One is that the model is not good, that predictive model is not good. Things change. We treat people differently. We have a better critical care and so on. It may just also mean that our sample size is just too small to see a difference. You can have a couple more people in the bad group that will just switch things around. Or it might mean that there is something happening here. And we don't know. So there's something that might be happening there. So the limitations of this current analysis is one, is it's a small cohort. The model may be wrong, like I said, or there might be something happening. So where do we go from here? Well, just to quote Seneca, as a Roman philosopher around 465 AD, 4 BC. He lived in tremendous time, I suppose. He says, to err is human, but to persevere in error is diabolical. So it's something to think about. Now, we're doing innovative surgery here. This is something which is not standard of care. And I'd like to apply the ideal recommendations from this particular group from Oxford, saying that if you have some surgical procedure, it's innovative and something, you should not just apply it, you should study it. So we've already been through the phase of development. We've been through the phase of exploration. Now we're through the phase of assessment. And don't want to stay in this particular type of a situation. So this is what we're proposing. First, we're going to need to get more prospective data. And meanwhile, we'll also like to try to get a grant and get the eHIT trial. Not that he hit me, but eHIT. Emergent Hemicraniectomy and trauma with multi-center evaluation. And this should be a prospective randomized controlled trial. It should be multi-center. It's going to obviously use a larger patient population. It will have to be in the order of 300 probably to get the data that we need. And we'll look at longer outcomes because there are 6-month outcome. It's probably not long enough. At 18 months is probably more reasonable. And this is where we're at with this. We're still in a standstill in terms of taking these patients to surgery. It's still a dilemma whenever I get a phone call at 3 in the morning whether we should bring these patients to surgery because we really don't know. And we may be harming them. And if we follow the standard of care at this point, you should probably not treat these patients the way we are, but we still are doing it. One other little thing we're going to be doing is sending out a survey, one of these monkey surveys to neurosurgeons across Texas, giving them scenarios and see what is the practice out there, and get an idea of are we just the only ones doing this, or is it something which is maybe more worthwhile doing, and also to try to see if we can get some centers to participate in this trial. And thank you, and we're open to questions at this point.
Hey, thanks. Very interesting talk. You know, we all have our biases, and Cooper, in that study, that kind of a lot of what sounds like you're questioning, like the way you're approaching doing hemicraniectomy is based on Cooper's results that were published in the journal. So I contacted this guy, Cooper. Yeah, it turns out that when they randomized people and they had a standard therapy group, now that's a bias, calling the non-operative group standard therapy. They should have just called it non-operative. And the decompressive craniectomy group, a full quarter of the patients in the standard group had to undergo what was called emergent decompressive craniectomy for life-saving procedure, and then they were continued in the intention to treat in the standard group. How? That gets published in the New England Journal of Medicine? Wow! What? Like, that's like us doing a study. And I'm going to go back to this appendectomy in a moment. But that's like us saying, you know what, let's just randomize people. Antibiotics versus appendectomy. And it turns out antibiotics are great. That's our conclusions. Surgery, not so good. Turns out a full quarter of our people had to go life-saving laparotomy, but we continued that. Did you do post-hoc analysis? No, not really. My question to you is, how in the world could anyone base any kind of practice pattern off of Cooper's study when they had that large of a percentage of patients that needed what was called a life-saving decompressive craniectomy? If you weren't going to do it in his description of it, then a full quarter of those people would have died, changing the mortality rates and really, I guess, overall the Glasgow extended score outcome score. I don't understand.
There's a lot of ink being poured over this trial. I mean, I was at the CNS last year when they came to present the results, and there was the critique came afterwards, and just said exactly what you said. I said they demanded the immediate total retraction from the New England Journal of Medicine, and so on and so forth. But they did this in front of 5,000.
Well, so I mean, I don't understand. Like, so let me just that military study you pushed up there. So I called those guys. The one interesting thing about that study compared to tons and tons of other retrospective analyses that aren't necessarily anecdotal. We can't just say all these retrospective analyses, those are anecdotal. Not really. I mean, they're not great, but they're not anecdotal. The difference between that study and all the rest of the ones that I've read, the biggest ones coming out of shock trauma and Memphis, are the average time to craniectomy is like 4.5 hours for the military group. The average time to craniectomy in all those other studies, like 16 hours, 12 hours, upwards of 30 hours, depending on the study. You're right. So this is my point. Trauma surgeons, we look at you guys like, well, we are. We're racist. We're neurosurgical racists. Trauma surgeons approach the patient like this. Yeah, just pop the top of their head off. What are you doing? Just take it off. And it always is strange to us that you would even think, well, you know, I don't know what the outcome's going to be. Yeah, I don't know what the outcome's going to be. I'm going to drive home, but I'm going to drive home. I mean, why don't y'all think about it that way?
Because of this.
I still don't get it. So, see, I would say y'all still practice this way. Yeah. And really the way to practice...
Knowledge doesn't give you the right to do things.
Okay, so we would argue that there is no standard of care for decompressive craniectomy in the diffusely axonally injured. True? Every other thing, though, Brain Trauma Foundation says, you have an epidural that's this big, it has this much shift, you operate. You have a subdural this big, you operate. You have an intraperitoneal hemorrhage this big, you operate if it has this. I mean, it's spelled out.
Well, there's no class one, is it?
So we're not going to do what the Brain Trauma Foundation says, or we are going to do it? Okay. Here's what I would say. I bet you, if you were to randomize just doing it, you have a CT scan that looks like that, bang, you get a hemicraniectomy. Versus, well, let me think about it, I don't know, ICP. By definition, ICP, refractory management, those are going to be patients that are doing poorly anyway. I bet you the would do better.
That's what we want to study.
That's what everyone wants to study. My question to you is, what?
Keep going.
My question to you is that what y'all are going to do? Are you gonna in the eHIT me? Are you going to say, all right, they have this, we're just gonna operate?
I think what we've also, with our pilot data, we identified a group of patients that may benefit from it. I think we've identified two groups which probably don't benefit and that may actually cause harm. There's a 30% complication rate of hemicraniectomies. It's not a benign operation. You may think it is, but it's not. So there are problems. There's more hydrocephalus, you need shunts, you get bone type infections, and so on and so forth. It's a risky procedure. You think it's simple, but it's not. So we identify the ones who you think are going to die. Prediction is very poor outcome. I don't think you should operate on those. You're just going to create vegetables. And there are things which are worse than death, in my opinion. Maybe not all of you. There are things worse than death. And there are people who would have unnecessary surgery, which is a really bad thing to do.
So that brings me to the Memphis paper. So this Memphis paper, one of the best things that I've read in craniectomy literature is that paper, and the people who were arrived in a post-resuscitative GCS of 3, 17% of them had, I can't remember if they used the extended outcome score or the Glasgow outcome score of pretty good, like pretty functional. 17% of them.
We have to study this. You just can't.
I agree. It's just that I think that all of our biases lead us into certain mindsets that become.
I go back to the surgery days when gastric ulcers were irrigated with saline. There's a study that showed it made patients worse. It didn't work. Do you irrigate gastric ulcers with saline anymore?
I didn't even know you could do that.
That was standard of care.
But it sounds like you don't want I mean, the evidence out there that says hemicraniectomy could be bad.
We're practicing that way, so we think it is, but we don't know if we're doing the right thing. So I think that's why we think we should study. I'm totally with you.
Well, it doesn't sound like it. It sounds like
getting pushed by the trauma surgeons to get out and do these cases and pop the top off, like you say, and put them in ICU.
Well, what evidence out there says that hemicraniectomy is bad? Is it Cooper's paper? I mean, because all the other ones I've read, like almost every one says good.
Randomized trials. Rescue ICP will give more data also. It may be a bit more rigorous because the fact that Decker was so criticized, so they're going to be, it is more rigorous. The other thing, the problem with DECRA is that they screened 3,500 patients to randomize 150 over 7 years. So, it's not an easy study to do. And that's why we have to really get good bang for the buck. You can't do this for like the next 20 years and say it was futile because we can't get any patients. We have to make sure that this is feasible and doable. Dr. Stewart.
I guess to get to I mean, Jason had about 20 points in there, but to get to his point about the study, I think it's a very needed study. I think it's a needed trial because without it, I think the consensus opinion in the neurosurgical world will be that it's not good and you shouldn't do it.
Actually, the consensus in the neurosurgical world is that the DECRA study is bad. The surgeons don't like to be told not to operate. They like to operate. It's like that in every surgical trial. The surgeon's bad. It's like that in coronary bypass studies. It's like that in ECI bypass studies.
But those in general are operations that are done between 7 a.m. and 3 p.m. So surgeons like to do those operations, us included. It's so that I think when it comes at 3 a.m., there's a lot more decision making that comes into play about how good a thing it is to operate. So one thing, the only thing I was going to say is I think your results are very intriguing. I think you're exactly on the right track. Based on your preliminary data, though, I would not exclude that upper end, in other words, the group with the high predicted. The way I would deal with that in the trial is I would include those patients to get to the question about the Memphis study that Jason alluded to. But I would include them, but I would do it with the prospective plan that you're going to evaluate the data that your middle group that's most likely to benefit, and you're going to evaluate that top tier subset maybe separately. You just say that up front, and it makes total sense. The group that are the less severely injured, well, they don't need to have a decompressive craniectomy, so it seems reasonable to exclude them. I would include the upper tier.
But I would, I don't know if we could use what we have now just to kind of guide us at this point. Should we operate on these people with high predicted mortality at this point in time without being in trial?
I'm just going to say, first of all, doing the science, totally commend you, and it's great. I think the problem we kind of have with it is that, to me, this is just like a patient comes in with a ruptured AAA, a ruptured aneurysm, a blood pressure of 80, 70, okay? And our neurosurgery colleague give us what it translates to us hearing, well, let's give them some fluids and see if their blood pressure responds, and if in a couple of hours their blood pressure is okay, then we'll operate because they've declared themselves to be in the good survival group, as opposed to just sewing up the aorta. And your group is not practicing as aggressively as you suggest, just so you know, because we are getting a lot of, well, his Glasgow's 5, his ICP might be high, let's put the ICP monitor in, let's wait a few hours, and the next thing we know.
That is standard of care.
Understood, but that's not what you said you're practicing. You said you're practicing a very aggressive early decompressive craniectomy practice, and you do have a few patients. But of those few, some of us think there should be 3 times that many or 5 times that many. And so you might look at what time of day these patients came in, and I suspect they're more aggressive during the daytime than they are 2 in the morning.
Not really.
I think it depends. I think you're practicing like the rest of the world because it's very heterogeneous. To me, it's less dependent on what time of day it is. It's more dependent on who the attending faculty is. It sort of is a matter of philosophy.
I'd be interested if your operation helped USMLE scores or possibly the 535 members of Congress. As a snide comment.
Did you say you need one?
No, but I think Adelot does. I think his ICP was around 40. And Dr. Mueller, I saw the look on your face. Nobody would criticize you if you would have gotten up and moved over 2 more days. Thank you very much, Dr.